All right, so my name is Russ Derry. I'm the Director of Education for Epilepsy Foundation of Michigan, and tonight's Learn and Share conference call is Epilepsy and Physical Health, and we're very happy to have with us Dr. Yanny Phillips, who is an epileptologist with Bronson Neuroscience Center. So Dr. Phillips, welcome, and thank you for joining us.
Well, thank you so much for having me, Russ. It's a real pleasure.
Great. So can you start out by just giving us a brief overview of your clinical and research interests and also how any experience that you have with this particular topic?
Sure. I'm a neurologist specializing in epilepsy care at Bronson Hospital in Kalamazoo. Here I admit patients to Bronson's epilepsy monitoring unit for video EEG evaluations. I also see patients in my clinic in both Kalamazoo and Battle Creek, Michigan for management of intractable epilepsy, new onset seizures, and a variety of other neurologic conditions. I'm from Boston, Massachusetts originally, but I've been living in Michigan for about 15 years since medical school and my PhD at Michigan State University. My research interests are in brain connectivity and in electrophysiology, and so I did my doctoral research in neuroscience there. Both my neurology residency and fellowship were also at Michigan State University, so I'm a pretty big Spartan. I guess that's pretty much it.
Okay, great. So, as the title suggests, we're going to be talking about epilepsy and physical health and some of the different factors that are related to epilepsy and its treatment that can impact physical health. So, it's pretty startling, but on the 2005 Behavioral Risk Factor Survey, this is a survey that's done every year, and in 2005 we were able to include some questions on epilepsy, and we found that adults with epilepsy or a history of epilepsy were more likely than those without epilepsy to report fair or poor health, obesity, smoking, diabetes, physical inactivity, arthritis, physically unhealthy days, or activity limitation than the general population. Again, that we're not sure. There's many different reasons that probably play into that, but on this call, we're going to focus on some of the different ways in which epilepsy and its treatment can impact physical health. We'll also talk briefly about how healthy behaviors can impact seizure control. So let's start by talking about the physical impact of recurrent seizures. Can you talk about some of the most common injuries caused by seizures?
Sure. Perhaps head injury is probably the most commonly reported seizure-related injury. Fortunately, these are typically mild. This is predominantly seen in generalized tonic-clonic seizures where there is a loss of consciousness, but can also occur with atonic seizures or any type of seizures with impaired level of consciousness, and the patient's not fully aware of the environment. Other common injuries also include tongue trauma, bumps and bruises, shoulder dislocations, and even bone fractures. I remember my very first seizure patient I took care of as a medical student who had a substantial trauma to her tongue. She had nearly bitten off the entire right side, and there was just so much blood that she needed surgery. I've seen burns as a result of seizures rather seldomly, but it can occur, especially if a patient has an occupation of working in a kitchen or cooking at home. Those are mainly the types of injuries I've seen.
And are there any injuries that are somewhat unique to post-seizure injuries? I mean, things that you don't see in many other circumstances, or are most of them the same types of injuries you might see from any kind of fall?
So both. So we talked about my very gruesome first seizure case as a medical student with a tongue trauma. So tongue lacerations really isn't something that I see commonly in other arenas, not with that kind of frequency anyway. and of course, head traumas can result from a variety of etiologies, but seizures, something that I've commonly encountered.
Okay. And do any of these injuries, if they happen often enough, have the potential to turn into chronic health conditions like chronic back or neck pain or osteoarthritis, or the thing that you've heard a lot more about in the news lately with the NFL is the chronic traumatic encephalopathy? Are there any cases where just repeated falls or repeated blows to the head or any of these different injuries that we talked about over time can become chronic health conditions?
Oh, sure. You just mentioned a big one. So this condition, the chronic traumatic encephalopathy, this is a hot-button issue, especially for sports, and you mentioned the NFL. So this is when the brain degenerates and there is progressive loss of brain cells occurring following repeated head trauma. This is from a variety of causes, so sports like boxing, hockey, we talked about American football, also physical abuse and recurrent seizures. So clinical signs for chronic traumatic encephalopathy are memory loss, poor executive functioning, maybe personality changes, behavioral problems like depression, irritability, impulsiveness, and even suicidal tendencies. There are pathologic changes on the brain that we can see as well. Another chronic condition that I've seen, sadly not uncommonly, are repeated shoulder dislocations requiring reoperation that ultimately cause shoulder instability over time. And of course, any insult to a body, injury sustained during seizure, if encountered often enough, can have potential to lead to more complicated cumulative injuries.
Right. So many of the symptoms that you mentioned with chronic traumatic encephalopathy are symptoms that are common in epilepsy anyway. So how can patients, if they're experiencing some of those symptoms, I guess what's the point at which you would consider getting evaluated specifically for chronic traumatic encephalopathy, and are there specific treatments for that are different from those for epilepsy?
I'll answer this in two parts. So, absolutely, sometimes it's difficult to differentiate, what is the cause, because there's so many overlapping symptoms. Right. So vague neurologic symptoms like memory loss and forgetfulness and difficulty with executive functioning. You can see this with epileptics during post-ictal phase, as well as even with medications, anti-epileptic medications too. People with epilepsy can suffer from these types of symptoms. So I think the hallmark for the chronic traumatic encephalopathy is the history of trauma, of head trauma, right, and monitoring. The monitoring of symptoms recorded over time with progressive or decremental functioning over time. And of course, you mentioned testing, so MRI changes. We see this type of cerebral atrophy that not only is there a generalized volume loss, but there are other hallmarks that you see with MRI changes as well. And then, unfortunately, a lot of these patients that are diagnosed with chronic traumatic encephalopathy, the diagnosis is clinched during postmortem autopsies. So, but there is a lot of overlap. So I think history is most telling in helping to differentiate. And then the second part to that, with treatment, so chronic traumatic encephalopathy, this is largely early recognition and supportive care, so that patients are getting the proper management. But there's no curative. There's no cure to take away the symptoms. It's non-reversible. Not suffering further trauma to the head would be helpful. Right. And it's common sense.
And And just to clarify too, it doesn't necessarily need to be a concussion or a traumatic brain injury or repeated. It could just be more subclinical.
Absolutely.
That if they happen enough times, it can lead to that. Okay. So what are some common sense precautions that can reduce the likelihood of injury without unnecessarily restricting activities?
I think you just said the key word there is common sense. So certainly there are driving restrictions, that are state specific in terms of reporting and duration. So in Michigan, it's 6 months seizure free. Mm-hmm. But there is no law restricting every potential aspect of harm in someone's life. Certainly, until sustained seizure control is achieved, activities like swimming, surfing, rock climbing should probably be best avoided, or made sure that somebody else is with you who can ensure your well-being if you are to lose consciousness. So, furthermore, patients, if they have occupations requiring things like navigating heights, so roofing jobs, window washing, or operating forklifts, heavy machinery. And in these scenarios, I highly recommend these patients talking to the employer about changing job responsibilities. Obviously, my goal of treatment is to help my patients gain seizure freedom and their independence, to do all the things they want to do to optimize their function and their quality of life. But until that goal is achieved, learning to minimize risks is a critical part of living safely with seizures. So actually, I do tell all my epileptic patients to use their common sense and not to engage in activity that can cause injury to themselves or to others if there is an unexpected sudden loss of consciousness.
Right.
So along that line, educating family members, caregivers, as well as the public at large is also very important. Seizure safety, so that bystanders know what to do and a lot of times what not to do when witnessing a seizure. So things like moving sharp objects or hard objects, like furniture, out of the way. Mm-hmm. If they see a patient is at risk of falling over from height, or either they can lower them down into an area of safety if possible. If they see that person is choking on their secretions, try moving them into a position to avoid aspiration. These all sound intuitive. So other things, like things what not to do. Don't insert an object into a person's mouth, as this can cause injury to them and to yourself.
Right. Have you seen any instances of people who have been injured specifically due to a bystander providing incorrect seizure first aid, either by not doing anything or by doing something they shouldn't have done, like trying to restrain the person, or like you said, put something in their mouth?
Yes, actually, I have, Russ. Mm-hmm. Two different scenarios. Patients. So don't try to hold a patient or restrain them during a seizure, because you can hurt them. So one of my patients had a shoulder dislocation just from that alone. His dad was trying to hold him during a seizure, so this was a bad idea. And then several months ago, one of my patients' grandmother, she just started taking care of him and wasn't aware of his seizures. So she saw him seizing and his jaw locked up, and she was terrified that he was going to bite his tongue off. So, bless her heart, she screamed for help and tried to pry open her grandson's mouth to stick her wallet or something in there to keep it open. Needless to say, this was very dangerous. So she did not succeed and ended up getting her right, index finger severely bitten. Wow. So both of those highlight bad scenarios. Yep. Another thing is, so along that line, I think, patients definitely taking the lead and developing a seizure action plan or a seizure response plan with family and friends and their coworkers, colleagues, or if they're in school, their teachers, is crucial to success in overall seizure management. So, some people find it helpful to have a tailored plan so that they know what should be carried out in the event of a seizure happening.
Mm-hmm. And what do you recommend in terms of obviously it's individualized and every person has to decide if they want to do this, but what do you recommend in terms of medical ID to prevent a bystander from incorrectly reacting to a seizure?
So, it's very individual. Some people wear medical alert bracelets to alert others that they are, they're not stumbling around drunk. They are epileptic and likely post-ictal right now. That can be helpful. Having so something tailored to individually to their specific seizures. If their seizures always, result in a certain type of phenomenon, if they always have weakness on the left side of their body after their seizures, but they're not able to speak to let others know that no, I'm not having a stroke, I'm having a seizure. They're not brought to the ED and treated inappropriately. So having, I think it's useful to have some plan written out. It doesn't have to be very, very detailed. Doesn't have to be, a lot of work, but some plan tailored to their specific needs, maybe written out and carried in their wallets or some on their person. So when they travel, they may not necessarily be with another person, with a family member or caregiver. So the other thing is bystanders. Not only do they need to know, be educated in what to do and what not to do that we talked about earlier, but also to keep a level head and to keep track of how long somebody, their loved one is or their friend is seizing, particularly during convulsive seizures, because sometimes a 30-second long seizure can feel like it's an eternity. Right. But it's very important to keep track of time. In cases of convulsive seizures or generalized tonic-clonic seizures, otherwise known as grand mal seizures, these usually last about a minute or 2 minutes. But if this seizure is ongoing for longer than 5 minutes, this person needs urgent medical attention because this seizure has the potential to not stop on its own and can develop into life-threatening condition called status epilepticus.
Right. Okay, well, speaking of generalized tonic-clonic seizures and to a lesser extent complex partial seizures, they can bring about a number of physiological changes, that some of which last for minutes, some last for hours, and some may even last for days after the seizure itself. Can you talk about some of these changes and the resulting physical symptoms that people may experience after a seizure?
Sure. Generalized tonic-clonic seizures, as the name indicates, is a seizure that's characterized by abnormal electrical discharges involving the entire brain simultaneously, kind of like an electrical storm in there. Clinically, during the tonic phase, so this is the stiff phase, this comes first and all the muscles stiffen up. That individual assumes a rigid, extended posture. This is due to extensor muscles overpowering the flexor muscles. Usually breathing is arrested, and there may be a groan or a guttural cry that you hear. This is caused by air being expelled out from the lungs through the closed glottis. That person at that point can lose consciousness and may fall to the ground. Hopefully there was somebody there catching them. They may bite their tongue or their cheek. That person may also have perioral cyanosis. So this is when the lips look blue and dusky. After the tonic phase usually comes the clonic phase, where there is repetitive synchronous contraction and relaxation of the arms and legs, usually distally. I think anyone having witnessed a seizure knows what I'm talking about. This is, looks very violent. And this is followed by complete relaxation as the electrical storm dies inside the brain. So this is usually about 30 seconds up to 2 minutes. There may be a loss of bladder or bowel control from the autonomic overflow. And then gradually consciousness returns. During this period of time following a seizure, called the postictal state, that person may be very drowsy, confused, agitated, tired, and may have a headache. This period can last minutes, can last for hours or even days. And depending on the duration of seizure, that person has extreme fatigue, muscle fatigue specifically, because physiologically it's as if they run a marathon. Especially during longer-lasting convulsive seizures, there is significant muscle breakdown from localized muscle hypoxia during the seizures. So lab-wise, they can be elevated CPK, which is a nonspecific marker of muscle breakdown. Actually, there's been some cases where there's so much profound breakdown of muscle that patients ended up having acute kidney injury.
Oh, wow.
Physiologically, during a seizure, there's massive muscle activity that can also lead to hyperthermia, in addition to the increase in lactic acid levels. These levels can be markedly increased, but this is self-limited and then usually goes back down shortly after the seizure is over. There are a number of other metabolic changes that take place after a seizure, such as increase in blood sugar, increase in sympathetic tone, so there is elevated heart rate and blood pressure. These are temporary changes. And then in some people, the postictal period comes with certain symptoms as well. For example, they may experience mild or severe weakness in the unilateral hand or arm or leg. This is called a TOTS paresis or TOTS paralysis. It's common after usually focal motor seizures affecting either one limb or one side of the body, believed to be caused by exhaustion of the motor cortex, but there's no conclusive evidence. These symptoms can last up to a couple of days, and then this can be very confusing. So I mentioned earlier, I was talking about stroke, but sometimes it's very difficult, very confusing trying to differentiate whether someone's having an acute stroke or if they've suffered a seizure and now has a postictal TOTS. And I've certainly encountered this situation many times. Other people have difficulty speaking or experience temporary vision loss or other types of sensory symptoms. So there can be lots of different symptoms, like physiologic symptoms that can accompany seizures.
And for people who, most cases it's, a few minutes or a couple of hours until you're able to function again. But there are cases, I've heard many people report of being wiped out for a day or two. What's the main difference between those who recover after an hour and those who are really unable to function for a couple of days?
I think so. This is variable. The variability, I think, largely depends on how long the duration of what the duration of the seizure is and what type of seizure this is. So a focal motor seizure without any impairment of consciousness probably won't have a long postictal state. Somebody with a generalized tonic-clonic seizure that went on for 3 minutes may have a much longer lasting postictal phenomenon than the person with the focal motor seizure, or some people with simple partial seizures, now called focal seizures without these cognitive features. You would not expect a postictal state.
Right. Okay. And similarly to what I had asked before, if seizures and the resulting postictal states are frequent enough, is it possible for any postictal symptoms to have a cumulative effect and evolve into some chronic health condition?
So seizures indirectly can cause injury, as we had discussed. a little earlier, as we talked about the chronic traumatic encephalopathy, but cognitive effects such as memory loss or memory problems, anxiety, depression, they're commonly reported in epileptics. Recurrent seizures itself, there is increasing evidence of structural changes in the brain associated with repeated seizures. So this is looking at experimental animal models and clinical imaging studies. So, for example, there are some MRI studies. I can't cite the specific study, but they looked at hippocampal atrophy, so the volume of the hippocampus, and correlating it negatively with duration of seizures, suggesting that these neocortical changes may be a consequence of seizures.
Yeah, and that's, from what I've heard, it's still unclear as to whether that's due to the repeated seizures or due to the underlying process of epileptogenesis, or if it's the underlying condition that's causing the epilepsy. Is that still fairly unclear as to which of those factors are involved?
Absolutely. So in my readings, there is no clear, conclusive evidence, but there's a growing body of research supporting this idea.
Okay. So seizures can also interfere with sleep, which can in turn impact physical health. Can you talk about how seizures can affect sleep and what can be done to address that?
Sleep, as we know, is essential for well-being in people with and without epilepsy. Sleep plays a vital role in epilepsy, since it may influence seizure recurrence, particularly in certain epilepsy syndromes. The recommended sleep for adults is about 7 to 8 hours to achieve optimal health and well-being. Sleeping too little or too much can have adverse health consequences, such as risk of diabetes, cardiovascular disease, and depression. In patients with epilepsy, not enough sleep can lead to, as well as anybody else, poor thinking, poor memory, low mood, high anxiety. These things combined can lead to sluggishness and lower exercise levels, which in turn can result in weight gain, metabolic disorders like diabetes. Weight gain and obesity can conversely cause poor mood, low self-esteem, and so on and so on. So this is a vicious cycle. I think it's important to find out the cause of sleeplessness. Is this voluntary? Are they just too busy? Like teenagers have so much going on with their texts, with their phones and computers and video games. Is there insomnia or something more pathological, like I'm blanking on what I want to say. Sleep apnea. So, with concern for sleep apnea, I recommend referral to sleep experts for proper diagnosis and treatment. And if possible, I guess my preference is I would favor promotion of non-pharmacologic treatment of sleep. So, employing good sleep hygiene, for example. So sleep is definitely very important.
Right. So it's possible that people with epilepsy have worse physical health than the general population, in part because of the underlying conditions that often cause epilepsy. So that can include stroke, cerebral palsy, intellectual and developmental disabilities, traumatic brain injury, and a variety of genetic disorders. So in such cases, these underlying conditions may contribute to reduced physical health more than the epilepsy itself. But if we exclude the effects of seizures and the effects of conditions associated with epilepsy, is there any evidence to suggest that epilepsy itself can negatively impact physical health? For example, does epilepsy bring about metabolic or structural changes that contribute to poor health?
That's a very good point. People with epilepsy have been found to be significantly less likely than their counterparts without epilepsy to engage in the recommended levels of physical activity. And one possible explanation is that epileptics may fear that exercise can induce or worsen their seizures or make them prone to injury. I think promoting more safe physical activity and what we just talked about, improved sleep quality, is necessary for optimal health and well-being in people with epilepsy. Exercise not only can provide cardiovascular and cerebrovascular benefits to people with epilepsy, but can also reduce their risk for other comorbidities such as depression and anxiety disorders. So depending on their risk, associated seizure risks, there can be range of other recreational activities that they can engage in that can be more suitable.
Okay. So we've talked a little bit about seizures and epilepsy itself. Now, anti-seizure medications are obviously another potential cause for a variety of physical side effects. The likelihood of experiencing side effects most likely increases in those with poorly controlled seizures because the doses are likely to be higher and patients are more likely to be on multiple medications. Based on the literature and your clinical experience, roughly what percentage of people with epilepsy experience ongoing side effects? And I'm referring to side effects that are significant enough for them to be considered bothersome.
So in my experience, it seems as though the side effects that are reported are usually reported initially. Mm-hmm. Ongoing side effects are substantially lower. So, with epilepsy, there's disease burden as well as burden from treatment. And treatment with AEDs, with anti-epileptic drugs, is generally chronic, if not lifelong, and they all have potential side effects, and these side effects present differently from one individual to the next one. So when I choose a anti-epileptic drug for a particular patient, I obviously want to choose a medication that is best suited for this particular patient's, not only their seizure types, but what else is going on in their bodies. What are their other comorbidities? Are they trying to get pregnant in the future? Are they do they have ongoing kidney disease or liver disease? So obviously, we want to choose a medication that is most suitable for them first to avoid side effects later on, because the more that we switch medications with cross titrations and everything else, the more likely we can cause breakthrough seizure. So so it's best to choose the best suited medication as the first medication. Right. But sometimes this can not be avoidable, and patients end up having ongoing side effects that does not resolve, and then at that point, I need to switch them to something different that they can tolerate better. So even if the seizures they are seizure-free or doing really, really well seizure-wise on a certain medication, and they're not able to tolerate the side effects, this patient's not going to want to take this medicine. So at the end of the day, it's not going to help their seizures if they're not taking the medication.
Right. So do you have I know it's impossible to come up with an exact number, but do you have a rough approximation of about what percentage of people have persistent ongoing side effects? Because the reason I ask is I do think, just in talking with people, that people sometimes tend to overestimate the frequency of side effects or how common they are. And if they're having a symptom, they seem to be more likely often to attribute it to the medication than to the epilepsy itself. So, for example, depression or memory problems, they're more likely to say that that's due to the medication sometimes than to the underlying condition that's causing the epilepsy. So do you just have is it like 20% of people? Is it 50%? Is it a ballpark of like how often people have ongoing side effects from their medications?
I would say probably about a quarter of patients, up to 50% of patients, still complain of side effects that can be very real. And obviously, once we've exhausted, we tried these medications, tried them through, and we find the best one possible. They may still have some persisting side effects that's unavoidable. Sometimes, like you said, it's not related to the medication or the seizure itself, but it may be coincidental, or sometimes they're just more in tune, that they're more alerted to what's going on in their body when they're started on the medication. So, so whatever is going on, they're attributing it to the medication because they just started on this medication. So I typically tell patients, let me know. I educate them about what they can expect, what are the common and serious potential side effects of whatever medicine I want to start them on. I review these side effects extensively with them. I make sure that they understand what they're taking in their bodies, and tell them that if you have this side effect, you may, for example, Topamax. Expected side effects are, you may feel some trouble thinking, some word-finding difficulties, maybe a little drowsiness, a little tingling in your tongue or your fingertips, and if you drink soda, it may taste a bit weird to you, but these things should usually go away after, a few weeks. So they know they're anticipating these side effects, and they don't get worried that, oh my God, I'm having a stroke, or something else is going on. And I let them know that, they should go away after this period of time, and it's still ongoing, and you're, despite, being at, not because I'm making any dosage adjustments, and these symptoms are still ongoing, and it's so bothersome that it's disrupting your quality of life, you got to let me know, and we'll switch you to something else. Most of the time, with understanding, patients, these symptoms do pass, and I don't hear the reports of ongoing side effects from that standpoint. I also make sure that they understand there may be other things going on. Maybe it's not just the medication, the anti-epileptic medication itself. So they, I want them to tell me still, so that we just we want to make sure that it's not the medications, or they're having adverse side effects from the medications. But so it's just so that they keep an open mind that there may be something else going on too.
Right.
I had a patient once that, actually this is not just once, but there's one that I saw quite recently, who kept saying that, I forgot what medicine actually I have him on, but he had he was just started on an anti-epileptic medicine, and just every time he takes this medicine, he swore to me that he feels sweaty all over, and just his legs feel like jelly, and he falls to the ground, he collapses, or his legs fold in, and just kind of like a weird side effect. Of did lab checks and had to monitor it. I actually had him had his family doctor, do a full cardiac workup just to make sure that, gosh, is there something else going on there with his heart, or some metabolic disorder? And he saw me back a couple months later, and still having the side effects, and all his testing were unrevealing. And so I slowly transitioned him into a different medicine. I took this medicine off, and at first, he thought, oh yeah, this is better, but I don't know how much of this is like a placebo effect of sorts. But symptoms came back, and so he saw his doctor for further testing, and so anyway, long story short, it turns out he has an endocrine-secreting tumor, but it was really difficult to find at the time, and it wasn't anything to do with his seizure medications, but it's hard to figure out. He still has persisting, ongoing side effects that I was not anticipating from this medication. So sometimes that happens, and it's hard to figure out whether it's the medication. So monitoring is important, education of the patient is important. And then at the end of the day, if we can't figure out, what it is, and they're still having side effects, if this patient can be transitioned to a different medicine, that's what I'll try doing.
Right. So really, the bottom line is it's important to report any unusual symptoms that you're having, whether or not it's a side effect that can be determined, but just making sure that you're not only just reporting your seizures, but reporting other symptoms, which may or may not be side effects.
Yes.
Yeah. Okay.
Yes.
So while the goal of epilepsy treatment is no seizures, no side effects, there are times when patients may need to endure some side effects for the sake of seizure control. There are far too many side effects to discuss them all during this call, but let's talk about some of the most common physical side effects and what can be done beyond simply changing the medication to cope with them. So drowsiness, probably the most common side effect of all. When you look at anti-seizure medications as a whole, what are some ways to deal with drowsiness that's related specifically to the anti-seizure medication?
So drowsiness, actually, I've never had a patient tell me that they didn't feel drowsy when I started them off on a seizure medication, so it's very common. One thing that can be done, actually, I wouldn't say this is changing medications, but timing of when these medications are taken can help. Drowsiness symptoms typically is seen during the starting of an anti-epileptic medication and during dosage adjustments, and typically resolve or improve as the body gets used to this medication over weeks, days to weeks. It's usually not a significant side effect after a patient's been stable on a certain dose of anti-epileptic medication, unless patient's on a very high dose of anti-epileptic medication. But there have been some extended release formulations of medications that's come out in recent years that have helped address that. So, for example, topiramate, Topamax, that's a medicine that has come out with a extended release formulation that has been helpful for some patients that do really well on this medicine but just can't handle the drowsiness symptoms, particularly when they take their morning dose. For this patient, converting them to an extended release formulation where they can just take the dose, the total daily dose at nighttime, can help mitigate the symptom. Other ones include trileptal, so there's Oxtellar, and Keppra has an extended release as well. So these are methods too that can help.
Okay. And fatigue or low energy is another common side effect. Is that I wonder if there's any different response to that than with drowsiness, or is it basically the same sort of approach as with drowsiness?
For me, it's I don't know if you know, but yeah, for me, this is the same approach with with this to tackle this patients with this type of side effect. Sometimes fatigue and low energy, it's a very vague, the diffuse complaint that can be caused by a number of factors that doesn't have to be neurological or medication related. So if there's constant chronic fatigue and low energy, despite being on the medications for some time, I actually do recommend further investigations to rule out other underlying disorders like hypothyroid disorders, anemia. Sometimes it can be mood related too.
Right. What about gastrointestinal complaints? And that's the whole spectrum of gastrointestinal complaints can be possible side effects. So what are some ways to deal with those? So I don't see this a lot, Russ. I don't get a lot of complaints with GI symptoms, but timing of meals, that's
that can be helpful. I've seen this, in a few occasions, and I think timing when the meals are taken along, when the medications are taken along with the meals, can be helpful for that. But I don't see this very often.
Okay. And similarly, weight gain and weight loss, which may be related to gastrointestinal complaints, it may be related to appetite or appetite suppression, or it may be related to metabolic changes that are brought about by the medication. But in any case, how do you deal with weight gain and weight loss?
So most of the, I guess, 26 different anti-epileptic medications we have out there, they can cause weight gain. I think Topamax or topiramate is one medication that potentially can cause weight loss. So weight gain, particularly in older generation anti-epileptic drugs, can be a substantial side effect for a lot of patients. So that, we monitor that, and, I recommend counseling on nutrition, and a lot of it is education and self-monitoring. And this continues. So if I have a patient that's already obese and borderline diabetic or already diabetic, and they're on a medication that I know to be likely contributing to their weight gain, I have not uncommonly switched them to something that I think would be more weight neutral and less likely to cause further weight gain.
Right.
For weight loss, this is not usually a big problem. I have had some patients, for example, teenage boys who are very thin anyway, and they're growing, and if I give them medication like topiramate, that can further their weight loss. So that's probably not the medicine I would want to start on that population.
Right. So a lot of that has to do with initial selection of medication based on their current weight. And
right.
Yeah. Okay.
Right.
So,
and nutrition.
Yeah. So dizziness is another common complaint. Is there anything specific that can be done with that?
So again, dizziness is often seen, usually during either patients when they're starting on a medication, on an anti-epileptic medication, or during dosage adjustments, or during when they're taking high doses of anti-epileptic medications. So there isn't any medicine that I know of that they can take to counteract the side effect if there's concern. Obviously, if this patient already, especially in an elderly patient who is already at fall risk, and they're taking it. So for that population of patients, I don't want to put them on a medicine that further causes dizziness and somnolence to increase their risk, more risk of falling and hurting themselves. So choice of medication, would come in handy, would be important for these patients. Dizziness, again, it usually resolves after the patient's been stable on a medication for a longer period of time.
Okay. So headache is another possible side effect, but it's also something that could be caused by a number of other things, and is also migraine in particular is just simply associated with epilepsy. We're not sure what the causal relationship is there, but how do you deal with headache that's possibly related to anti-seizure medications? Is it just simply the same, you treat it as independently, like with anti-inflammatory medications or with migraine medications for migraine? So
for headache management, I have the patients do especially if this is new onset headache. They've never had headaches before. Now on this medicine, they feel like their headaches. There's onset of chronic headaches. I have my patient, keep a headache diary to monitor when the headaches are coming. Is this tied to the timing of the medications? Is there a relationship to foods? Is there some activity that can potentially be contributing? And if this is medication related and there's nothing else that can be explaining this, and they just have this adverse, or this medication has an adverse effect causing headache, I can either switch them to a different medication, or if I'm not sure, and I typically treat this independently. So for headaches, we want to rule out any pathologic reasons for headache, meaning secondary headache. Is there a neoplasm going on? Is there concern for, is this acute headache? Is there elevated is there papilledema? Is there elevated pressures, cerebral pressures? Or this is just a primary headache. I treat this depending on what type of headache it is. If this is one headache a month, I don't think this patient needs to be started on a preventative daily headache medication. So things like anti-inflammatories, like you just mentioned, or triptans may be helpful. However, this patient has 3-4 headaches a week. This is a chronic headache and needs to be addressed differently. So I may switch their medications, their anti-epileptic medications, to one that has a secondary indication for headache prophylaxis, or start them on a different on a headache prophylactic medication, a different one altogether, such as I'm trying to think of lots of words, blood pressure medications, antidepressants, things with indications for headache control.
Right. Okay. What about cosmetic changes that sometimes can be associated with some of the older medications, things like gum overgrowth or acne or hair growth or loss? Is there anything that can be done to reverse that other than switching medications?
So this is really about switching medications. So with gingival hyperplasia related to phenytoin use or chronic phenytoin use, and make sure that this patient is following up with a dentist for management there. To make in case of secondary complications from the gingival hyperplasia. But yeah, I switched the medications to something different. So these changes, these cosmetic changes, these are usually encountered in the older generation anti-epileptic drugs, like phenytoin. Coarse features, hair loss, weight gain.
Right. Tremor. Anything that can be done to deal with that? I certainly see a lot of patients who have tremor, presumably related to the anti-seizure medication. So it seems like something, in most cases, that people are willing to just deal with. But are there any things that can be done to reduce or cope with tremor if it gets substantial enough that you need to?
Yes. So tremors can come from medication side effects. Most of the time, I see this as a exacerbation or masking of their underlying essential tremors that somebody already has. Oh. It's normal. We all have physiologic tremors that can worsen when we are, nervous or anxious, and certainly anti-epileptic drugs can worsen that too. I can try switching, if this tremor seems to be related to a certain dose of anti-epileptic drug. I can try lowering this dose down, or changing the medication to a different anti-epileptic drug that may not worsen the patient's tremors, or if I see this not related to medication, or I can't switch the medication, I may start that patient on a medication that can potentially help with the tremors, such as Indorol, for example, which is a blood pressure medication. It can help with physiologic tremors or essential tremors. I'm trying to think of Primidone is another one that can help.
Okay. And lastly, sleep disturbances. Some anti-seizure medications can interfere with certain stages of sleep or increase the risk of insomnia. Is that again? Do you switch medications if that becomes a problem, or do you are there ways to work around those symptoms?
I do. So I don't want to be too hasty in because again, sleep disturbance, like earlier things that we talked about, it can come from multiple different etiologies. If you're not feeling well, you're feeling depressed, anxious, there's a lot of stress going on, you may not sleep well too. So it may not absolutely be directly related to medication. So we don't want to be too hasty in changing around medications, particularly if the patient's doing well on a certain antiepileptic drug. To take them off this drug may not be in their best interest. But there are some medications, there are some antiepileptic drugs that are well known to potentially cause insomnia. If I don't find any other reason for this, I have not uncommonly switched patients. So lamotrigine is one that I've seen not often, but I don't think it's unique, causing insomnia, and I've either had them take the medications early on in the evening, or if there's nothing else that we can associate the sleep disturbance with, I've switched them off to something different.
Okay. So those are some temporary or more short-term side effects. Are there any potential long-term or permanent effects of being on anti-seizure medications for several years, and what can be done to avoid them?
Yes. So we talked about patient education and making sure that their understanding of what they're taking into their bodies and the potential acute and long-term side effects certain medications that they're taking can be. Aside from that, for a lot of the antiepileptic drugs, surveillance lab monitoring is crucial, as these can reflect underlying problems way before onset of clinical symptoms for patients, particularly when they are taking antiepileptic drugs that can affect the liver. Mm-hmm. So other things like I don't know if we talked about it earlier, but I, as a comprehensive approach to management of epilepsy, I frequently counsel patients on vitamin D and calcium supplementation, right. because antiepileptic. I'm sorry, my mouth is kind of dry right now. Let me take a sip of water. Antiepileptic drugs, a long-term use of this can decrease a person's bone growth, bone health, can increase absorption and breakdown of bones. Of course, reduce bone density results in osteopenia, which is a mild bone density loss, which can progress to osteoporosis, which is severe bone density loss. And there are no outward signs of this bone density loss, and so many people don't realize this until something bad happens. So I see patients in my clinic from 15 years old and up, and so when I tell this to my patients, my teens and 20-somethings population, that they need to take vitamin D and calcium supplements. They look at me like this is crazy talk because osteoporosis is for old people. Patients on chronic anti-epileptic drugs, they're at higher risk for bone fractures occurring with falls and other trauma. So early supplementation with vitamin D and calcium can really help prevent future injury. Besides, nice, strong bones and teeth are good for general health, well-being anyways.
Sure. And what do you typically recommend in terms of specific supplementation?
So, you mean dosage?
Yeah.
So calcium, this is age-specific. So in average size adults, about 1,000 milligrams, 1,000, international units, so about like 800 international units of vitamin D and about 1,000 milligrams of calcium. So this is what you can find at your local drugstore. Anyways, like I take them myself. They come in gummy bears. It tastes pretty good. Mm-hmm. So this, unless you have a diagnosed deficiency of vitamin D, in which case you may need to have higher than the 800 international unit, recommended daily dose.
Right. And at what point do you recommend requesting a DEXA scan or bone density scan? So in patients that have been on anti-epileptic drugs for a long period of time, I don't think there's any, at least not that I know of, any specific guideline as to when you get them. So patients that are that have been on anti-epileptic drugs for a number of years, and especially in a woman, and this is not elderly women, a woman older than the age of 50, I tend to start thinking about that, and I talk to them about it. Okay. And any other long-term or chronic or permanent side effects that are common enough to be worth mentioning?
I'm sure there is. I'm just not thinking of it right now.
Okay. One of the things was like peripheral neuropathy, specifically with Dilantin. Do you see that? Is that relatively uncommon for people who've been on Dilantin for a long time, or phenytoin?
I do see this. With phenytoin. I tend to, if possible, switch my patients from older medications, particularly, these medications that require monitoring, with routine blood monitoring. Most patients don't like that. If they can be offered something that has a better side effect profile that doesn't require this constant monitoring, most patients prefer that. So usually, changing the medications doesn't guarantee that the neuropathy that they are suffering from is going to ever go away. But this can certainly stop the progression.
Right. Okay, so epilepsy can also result in a number of behavioral and psychosocial changes that can impact physical health. So we'll just talk briefly about a few of these. So anxiety and depression, as we've kind of mentioned a little bit already, can impact physical health. And anxiety and depression are more common in people with epilepsy. Are there any things in particular that can be done to reduce that impact on the physical health? So
the most common psychiatric conditions in epilepsy are depression, anxiety, and psychosis. And despite how frequently we encounter this, depression and anxiety, especially depression, often remain unrecognized and untreated.
Right.
This is sometimes because patients, they tend to minimize their psychiatric symptoms for fear of, maybe being stigmatized. But depression is something that I see often with my patients with epilepsy. I think early recognition and therefore management of these psychiatric disorders in patients with epilepsy is extremely important, because this can improve quality of life. decreasing the suicidal tendencies and can aid in better seizure control. Antidepressant drugs and psychotropic medications. There is a fear that these medications can lower seizure threshold. So, there's a certain reluctance to use these medications with patients with epilepsy too. But obviously, everything that patients are prescribed should be prescribed based on a risk versus benefits. And I have this discussion with my patients that if the seizures are well controlled, or if they're on anti-epileptic drugs and they're having really they're having poor mood, they are feeling suicidal, they're having agitation that's disrupting their quality of life, disrupting their home life, their work life. Not uncommonly again, have tried to switch medications. There are some, so all anti-epileptic drugs can worsen depression. Some can more frequently reported to do this than others. So switching medications can help. And there are some anti-epileptic medications that have antidepressant and mood stabilizing effects too. So patients with underlying depression already, I probably would put them on a medication that can address the depression as well, and not to put them on something that may potentially worsen their depression.
Right. Okay. And I think we did talk briefly about exercise. The other thing I wanted to talk about is that with some people, the desire to improve seizure control may actually motivate them to practice healthy behaviors more so than they did before their epilepsy. Whereas with others, the epilepsy may be so overwhelming that they kind of neglect their overall health. So can you talk just briefly about the importance of healthy behaviors, not only in reducing seizures, but promoting overall wellness?
Oh, absolutely. I think you just said it right there. We talked earlier about how important it is to optimize our sleep behavior. Other healthy behaviors such as exercise, balanced diet. They not only promote good health in terms of cardiovascular health, but also help improve our mood, and general well-being. This can go a long ways to help with promotion of epilepsy management too. It increases adherence to medication, to compliance with taking their anti-epileptic medication drugs. So I can't talk about this more enough.
Right. Okay. Well, before we open it up to questions, did you have any remaining thoughts or concluding thoughts on this topic that you'd like to share, or should we just open it right up for questions?
I think we covered a lot of topics, Russ. I just want to emphasize that, overall goal in epilepsy management is to not only achieve seizure freedom, but also maintain optimal function and good quality of life. So keeping a healthy lifestyle, balanced diet, regular meals, not getting overly tired, getting enough sleep may help patients feel better and may reduce the chance of seizure recurrence. And of course, the best preventative measure is to comply strictly with the anti-epileptic drug regimen that's prescribed by patient's neurologist, because seizures cannot be prevented by lifestyle changes alone.
Right. Okay. So let's go ahead and open it up for questions and comments. Just a second here.
The conference is now in conversation mode.
Okay. Does anyone have a question for Dr. Phillips?
This is Marissa, and I have a comment and a question.
Okay.
I want to be able to, I agree with you, doctor, in regards to the taking the vitamin D and the calcium. I take Dilantin, and I've been on Dilantin for, I would say, about 5 years. And the doctor had, shared with me that it will decrease the bone density. And I'm an avid of taking vitamins. I take Centrum plus now I've taken calcium plus vitamin D. And even I talk to other people who are not epileptic, to make sure they take their vitamins. And as we get older, I'm close to 60. And as we get older, we need to replace what you lose. So I'm in agreement with taking the vitamin D and the calcium. Now, I would like to find out your opinion on the phrase I hear so much about people who are experiencing, especially grand mal seizure, and I got to put something in their mouth to keep them from swallowing their tongue. So what is your opinion on that?
Hi, Larissa. First of all, great job on being proactive with your health. I applaud you. I love it when my patients are taking care of themselves. It makes my job easier. So great job on taking your vitamins. Regarding your question about the putting something in the mouth, I personally don't endorse this. I don't know what device you're referring to. I'm not sure what's out there, but my personal feelings are don't put something in somebody's mouth. They can swallow this during a seizure, or in the case of that poor grandma one of my patients' grandmas, she lost a bit, or she got her finger really chewed up. So I personally don't endorse this. Okay. I hear so much about that, and when I hear it, I stop the person or people, and I would say, "Have you ever tried swallowing your tongue? Oh, take your tongue and see if you can swallow your tongue." And then that makes them think about it. And so I respond in saying that, the having the seizure and the muscles in the mouth and the teeth, the muscles going up and down. And so I said, you can't swallow your tongue. I don't know where that phrase came from, but I make people stop and think about it for a second. So I just wanted your opinion on it. I wholeheartedly agree with you. Me neither. I don't know where this myth came from. I don't know how you can swallow your tongue, actually. So yeah. I am in complete agreement with you.
Yeah, you wonder.
Okay.
You wonder if,
all right.
I'm guessing it's the derivation of that is that the tongue. If you're on your back, that in theory the tongue could sort of fall back a little bit and block the airway, or maybe it's derived from the injury to the tongue that can occur like you mentioned. But yeah, that is a curious and persistent myth that you can swallow your tongue. So
yeah. Okay.
Questions?
All right. Thank you.
Other questions or comments? Anyone want to share anything that that you have done to deal with some of the physical impacts of epilepsy or its treatment?
Hi,
go ahead.
This is Trinisa.
Yeah. Go ahead.
Hi, Russ. I had a comment and a question as well. I'm doing great, thank you. Most recently, I was speaking with my primary care doctor, and he was telling me that some vitamins don't absorb as good in our system. And it's funny that one of the ladies on the line mentioned Centrum, because he said that that's one of the vitamins that if you buy, you should buy as a gummy, because research has shown that the actual tablet does not really digest or dissolve in our system. And then he was also talking about how some vitamins compete with each other. For example, vitamin B5 can inhibit the absorption of biotin, and calcium can inhibit the absorption of iron. So I think that's important to, lay it out there as well to people on the line that certain vitamins can compete with each other, and certain brands even don't absorb in the body as well as others. But I did want the doctor's opinion on that information.
Hi, Teresa.
Hi.
Thank you for your question and your comments. So I don't know about specifically Centrum, but you're absolutely right. Certain the formulations on how the vitamins come in, that differs. And I don't know specifically what brands are better in terms of absorption, but in regards to the vitamin D and calcium, when you buy a multivitamin, oftentimes vitamin D and calcium are not included with them. So you have to be careful in actually looking at the back where they list all the ingredients or all the components of that vitamin tablet, what is included in it. But often the vitamin D and calcium are separate, or they're sold separately. So in patients that, especially of reproductive age, so anybody I'm taking care of, or over the age of 14 up to 50, I also advocate for them to take folic acid as well. Because most of the time, by the time that someone realizes they're pregnant, it's usually after they've missed their first period and after the critical stages in development, in neural tube development. So all anti-epileptic drugs can potentially cause harm to fetus, and so these are some of the preventative measures I take with my patients. Folic acid is also something that doesn't readily come in multivitamins, so I make sure that they are aware that when they're buying the multivitamin, to look in the back and make sure that what they should be taking is in fact what they're buying.
Oh, thank you so much. I appreciate it.
You're so welcome.
Yeah, and we discussed this a little bit in last month's call on complementary therapies, that other than the calcium and vitamin D, which is related to the bone density and bone loss, and the folic acid supplementation as a preventative measure for women of childbearing age, that there's really, and then the other one is I think vitamin B6, where there's a specific deficiency that can cause seizures. But other than that, there's not really much evidence that any specific vitamin supplementation can be beneficial for seizure control. But overall, it's not a bad idea to take a multivitamin just to help compensate for any nutritional deficiencies that you might have. Is that correct?
Sure, I would agree with that statement.
Okay. Other questions?
Yeah, I don't know of any other vitamins.
My phone's going to die real quick, so I got to get my question real fast.
Go ahead.
Sorry. My name is Kim, and I have non-epileptic seizures, and I've had them since age 27. I'm 42 now, and I have a lot of this, like every day, severe weakness constantly, and I get like the paralysis where I can't speak, I can't like move, and it can last quite a long time. Like today, I was like on the floor for 2.5 hours. I would be like really weak, and then if I try to get up, I'd have seizures, so I had to lay back down. I was just wondering if there's anything you can do for like the severe weakness.
Hi, Kim. So non-epileptic seizures, this is very common. I see this when I see patients with non-epileptic seizures quite commonly. Usually as a workup to make sure that they are not having epileptic seizures, because treatment is different. Typically, anti-epileptic drugs don't help non-epileptic seizures. In fact,
that's what's happening. I'm on different medicines. It's not helping.
Right, but it doesn't make the disease any less real. And it's unfortunately the treatment is less tangible, meaning that if you have a fracture in your arm, for example, you fix that fracture, and you can diagnose that easier, and the treatment is more well defined. Whereas non-epileptic spells, non-epileptic seizures, the treatment is harder. Typically, this comes from an underlying mood disorder, such as depression, overwhelming stress, anxiety. Sometimes patients don't even realize that they're stressed out, but their body is manifesting it. Sometimes stress can manifest as physiologically as maybe butterflies in the stomach or abdominal pains or nausea, vomiting. Sometimes people with anxiety disorders or stress disorders feel like they have heart attacks, that they can't breathe, they're gonna die. And sometimes non-epileptic seizures can result, but the treatment really is addressing the underlying cause. So if this is underlying depression that is not being well controlled, then this really needs to be addressed in order to get better. Because the important part about separating out a non-epileptic versus epileptic seizures is that you don't want to be taking an anti-epileptic medication with all the potential side effects that we had, discussed on this broadcast, but none of the benefits. So once you identify that your events are non-epileptic, then this needs to be addressed with proper medications or counseling. And I rely heavily on my psychiatry colleagues for help with that.
And have you ever heard?
One thing, real quick.
Go ahead.
Kim, was that your name? I'm sorry, my memory is really bad with all
I'm Kim.
Hi, Kim. I'm Brandon. Pleasure to meet you. Have you tried medical marijuana, or there's also ways to because all mammals they're discovering produce natural cannabinoids, just like our body produce other chemicals to do like adrenaline and such, and we have special receptors throughout our all of our organs, like our skin and such. But so there's other chemicals that like CBD, CBA, I believe, and like they're finding hundreds of others but I was born premature with epilepsy, and I went most of my life until my health got bad to the point to where I didn't have the energy to use the natural disciplines. But there's psychology definitely would definitely help, because and there's other things that you can do also, such as learning mental discipline, with martial arts, and with controlling your mind to the point to where you can naturally induce your body to produce things like the cannabinoid. It's like you can get your body to naturally produce adrenaline when to do something, whatever, on command. You can do the same thing. It takes a lot of energy, a lot of work, but it is possible. It's definitely something you might look into. Just a thought.
Okay.
Right, and certainly
it helps me.
Certainly the mind-body techniques, and we kind of talked about that last month as well, as anything with relaxation techniques, exercise can bring about real changes, and all of these things are other approaches that you can certainly try that are going to only benefit your health and may end up helping with your non-epileptic seizures. But as far as the weakness, is that something, Dr. Phillips, that you've ever heard of associated with non-epileptic seizures, like long periods of weakness and or even paralysis, like Kim mentioned?
So, Kim, if your neurologist has not evaluated this, so weakness, depending on whether it sounds like what you have is generalized weakness, meaning you're weak everywhere. This can there's many causes that can lead to generalized weakness. From is it feeling of weakness or muscle fatigue, to neuromuscular disorders can cause weakness too. So it's important to investigate and to rule out other pathologic reasons why you can have, generalized weakness, and make sure that, is there anything that's treatable. At the end of the day, if everything is ruled out and there is no underlying neurological or other reasons for your generalized weakness, stress disorders, mood disorders can also cause us to feel sluggish and weak all over as well. But I don't think this should be a diagnosis you get. It's a diagnosis of exclusion, so it's after you ruled out other things that can be causing your symptoms before getting this diagnosis.
Okay.
Okay. Have time for maybe one more question?
I'm sorry. I had a question about the bowel movements. My phone had hung up right when she brought up the topic, and I wanted to see what she was saying because I'm having problems with my bowel movements, and they just all crushed up and come out like a big old, like I'm taking an animal. And I have problems with my appetite. I only eat like once a day. I don't start getting hungry at all until about 1 o'clock in the evening. I don't have no taste buds at all.
Okay.
And like I say, when I go to the bathroom, it's like a big old animal.
Okay. So
it splashes everywhere.
All right. So that's Dr. Phillips mentioned that you said that you didn't see gastrointestinal complaints very often, but this may be a case where it could be a side effect or it could be a separate, completely separate condition. What are your thoughts, Dr. Phillips?
Is this during? Is this when you started on taking anti-epileptic medications, or has this been ongoing for a long period of time?
For a while now, since my medication's been cut down. Last year, I had a big old episode, and I ended up staying in the hospital for about a week. I didn't remember. I got tied down and everything. I kicked the nurse and all that, they said, and I don't remember any of it. When I woke up, they had me tied down. When I woke up, I saw my doctor and my cousin in the hallway talking. They told me a lot of stuff that went on during my cousins and stuff told me a lot of stuff that went on during the period that I was there that I still don't remember.
Okay. Sounds like you had
I have different kind of seizures. Yeah, I have grand mal seizures and then sometimes
Okay. So in general, I think history is very important if trying to figure out, is this causative? So if you've been on a medicine for a long period of time, and all of a sudden started having trouble with bowel movements, it's less likely to be caused by a medication, especially if there's been no changes on it. So looking for other underlying reasons for this, is there a bowel obstruction going on? Is there, has your doctor done any other studies to make sure that there is not such as a
now he just sent me for a sleeping disorder, and they said something about I was breathing 20 times or something. They want to put me on a machine now.
Okay, for sleep. Okay.
They took me for a sleep disorder study, so they want to send me, they want to show me how to use this machine to clear my oxygen.
The CPAP machine? Sure, no, that's very important. That's very important to address sleep apnea. It can improve your seizure control, it can improve your mood, can improve your memory. A lot of people have daytime fatigue but don't have they actually have sleep apnea.
Okay, and I pee all the time, and it's like all the time. Hello?
Hello? Yeah, no, I'm still here. So, yeah, but going back to your earlier concern about bowel movement, I think if your doctor hasn't done some investigations to make sure there's no underlying, so what am I talking about? What are underlying problems with bowel?
Bowel movement.
What I'm saying are, obstructions versus, do you have a motility problem? Or is it medication related? I think this definitely needs to be looked at because it can lead to further complications.
Okay.
Right. Yeah, I think in that's another important thing is that you should be working in your neurologist should be working in concert with together with your general practitioner, because some conditions may be completely unrelated to the epilepsy. It's not uncommon for people to have epilepsy but then have a completely separate condition that is also chronic and bothersome but is just a separate condition. So make sure that your neurologist and your general practitioner are communicating and they're aware of any conditions that you have.
Okay. Thank you.
All right, well, it's about time to wrap it up. So I want to thank you so much, Dr. Phillips, for your time and for a really great call, and thank you everyone for participating. And again, if anyone has any remaining questions, feel free to call me after the call or later this week. I'd be happy to try and answer those. So thanks again, Dr. Phillips, and everyone have a nice evening.
Thank you.